Thank you very much. It's a privilege and honor to be here. Thank you very much, Dr. Srinivas and Dr. Kasturi, for their very kind invitation. And today my topic is FFR for all my patients. So in early 2000s, when FFR became more popular in US, the number one concern as an interventionalist that I had was that now FFR is going to reduce my PCI volume. But as you'll see through this presentation, and which has come true into my own clinical practice, that our volume has actually not gone down at all by the use of the FFR. So many of you who is concerned that FFR is going to reduce your PCI volume, that's not going to be the case. Now why is that? FFR better defines, identifies the problem much better. So it's remarkable to see the discordance between what your angiography determines to be a significant stenosis and whether FFR classifies that lesion as physiologically significant. So if you look at the very left of this graph, you have moderate disease, that's 50 to 70%, but you can see almost 35 to 40% of these patients have physiologically significant stenosis. So a lesion that you see today in your lab in India that you think is 50, 60% and you don't think that you need a PCI procedure, with the FFR you are actually going to end up stenting those patients and your volume is not going to go down. And that's been the practice in our lab as well. FFR gives you more complete picture. So let's look at this artery that has angiographically 75% stenosis and it supplies a small amount of myocardium. Think about an example where you have an LAD that has 60% long stenosis in the mid-segment and you have a small circumflex coronary artery which has 75% stenosis. So this artery looks like a circumflex which supplies a small amount of myocardium by angiogram. And the same degree of stenosis in an LAD that supplies a large amount of myocardium, and the both FFR value is going to be significantly different. So FFR not only takes into account the degree of stenosis, also the length of the stenosis and amount of subtended myocardium, and gives you a much better picture in identifying the correct problem that you should be treating. It better defines the extent of the problem. Here's the data from the FAME trial where angiographically you may have classified the patient as 3-vessel disease, but when you add FFR information to this patient, only 15 to 20% of these patients had true physiologically significant 3-vessel disease. Now we're going to talk about that a little bit more as we go forward. It better selects the stenosis that may benefit from revascularization. Think about bypass surgery. Today in America, our cardiac surgeons, when I tell them to do a bypass surgery on a patient with 3-vessel coronary artery disease, his first question is, what vessels do you want me to graft? He's asking for physiological information on these vessels. So in this particular study, and there is quite a few of these, you can see that when the FFR is more than 0.8 and a bypass graft is put into a vessel like that, the graft patency is significantly reduced. There is a lot more grafts that get occluded when they are put into a vessel that does not have physiologically significant stenosis. So the impact on the bypass graft patency. So FAME trial, as you all know, has left a legacy of a treatment with FFR-guided revascularization in multi-vessel PCI versus angiographic guidance, and angiographic guidance was nearly not as good as FFR-guided revascularization. I won't spend a lot of time on this as you are very familiar with this data. There is very few trials in US that has really made the news. Courage is one of those trials, really created a lot of buzz. There was a New York Times article, there's multiple newspapers. Everyone said PCI procedure is bad, medical therapy is good enough, and my referring doctors now getting a patient with angina in their office are putting patients on just medical therapy and said there is no need to send this patient to a cardiologist because of this. Optimal medical therapy versus angiographic guided PCI procedure, albeit there's quite a few limitations of the COURAGE trial, showed no significant difference in the overall hard outcomes at 5 years in COURAGE trial. Now, let's think about the FAME, where we showed that FFR-guided revascularization did significantly better with angiographic guidance. Now let's take the medical therapy arm of the COURAGE trial and superimpose it on the outcome of the FAME trial. And you can now see that when you add a physiological information to your PCI procedure, you are beginning to now differentiate your therapy from just optimal medical treatment. The interventional community's response to COURAGE was the FAME-TRUE, which compared optimal medical therapy versus FFR-guided revascularization and optimal medical therapy. And you can see even very early on, within the first 7 days, you start showing a significant difference in the outcome between these two patients, mainly driven in the optimal medical therapy arm by return of these patients for urgent revascularization. But they just didn't come in with the chest pain. A lot of these patients had significant EKG changes and myocardial ischemia and infarctions, and that's why they returned. So there is clearly a difference between these treatments. Now let's think about how FFR may guide the choice of multivessel PCI versus CABG therapy. Here's an example of a case. This patient has a totally occluded right coronary, has diffuse disease in the LAD, and a tight stenosis in the SIRF. Now, you all know from the syntax 1 that if the syntax score is high, we should be referring these patients to cardiac surgery. So we calculated the syntax score in this patient. The syntax score in this patient is 32. We know from the syntax that this is a good case for CABG. Well, is angiography enough? I just showed you a second ago that angiography and FFR has a huge discordance, and when we actually use the physiology information, we define the disease much better and identify the right lesion to treat. So we should be adding physiological information. When we look at the appropriateness use criteria, a patient with a syntax score of 32, the PCI indication is class 3. Now, functional syntax is the new way of calculating the syntax score. We should not only look at the anatomy, but we should also add the physiological information to the evaluation of coronary artery disease in these patients. Here is a reclassification of syntax score by adding physiological information. So on the left, you see patients with a low syntax score, high syntax score, and a moderate syntax score. And when you add physiological information, you saw a large number of patients moved from a moderate to severe syntax score to a low syntax score. So we reclassified a patient with a severe 3-vessel disease to now a 2-vessel or a 1-vessel disease. Now, when we measured the FFR of this patient's LAD was 0.84. And we recalculated the syntax score by adding this FFR information. In the same patient that I showed you, now the functional syntax score of this patient is 18. When we add the functional syntax score to the appropriateness use criteria table, now your PCI indication is class 1. This patient got 2 stents in the circumflex coronary artery, went home, and remains asymptomatic. Syntax 2 further defines the problem and guides our treatment strategy by using a full PCI optimization concept, where we're going to identify the patient with FFR information, that who should be treated, and then optimize the stent result by using imaging technique. So in syntax 2, you had 1,100 plus patients, and you can see at the outset of the trial, 31% of patients had deferral of the PCI based on the results of the FFR. When you look at the number of patients in the syntax 1 who underwent 3-vessel PCI treatment versus number of patients who underwent 3-vessel PCI treatment in the syntax 2, when physiology was added to the equation, was significantly less. We know that the less number of stents we put in, the less number of vessels we treat, less complications, improves the outcome. 85% of patients in the syntax 2 trial had intravascular ultrasound examination for optimization of the stent treatment. Now, does this matter? It only matters if we can show improvement in the outcome. So let's look at the outcome. So the blue are the patients who had optimized PCI in the Syntax 2, and the red are the patients in the Syntax 1 who had angiographic guided PCI procedure. And you can see there's a remarkable, statistically significant improvement in the outcome when PCI optimization was done. Now let's superimpose the CABG data from the Syntax 1 and compare that to an optimized PCI treatment of the Syntax 2. And you can see that the Syntax 2 optimized PCI wins even against CABG. At least it's not inferior to a coronary artery bypass grafting in these patients. So the functional Syntax score better identifies patients with low to intermediate risk in whom PCI could be considered. Now let's think about multivessel disease in the setting of acute coronary syndrome, because many of the patients that come with acute coronary syndrome also has disease in the non-infarct related artery, and we need to determine what should we do. So here is data from Primulti on your right lower box, which looked at complete versus incomplete revascularization. On the left side, on the upper hand, is the data from FAME looking at patients with unstable angina and stable angina, and you can see that the FFR-guided revascularization was better, even in unstable patients, and complete revascularization was better than incomplete revascularization. Compare Acute, which is presented last year, specifically looked at an FFR-guided complete revascularization in the non-infarct-related artery that led to a better outcome of these patients than just plain old angiographic-guided revascularization in these patients, shown here. A last concept before I conclude is, should you measure the FFR again after your PCI procedure? And there are many reasons why FFR could be low, and in the interest of time, I'm not going to go into a deep discussion of why it could be. However, a post-PCI FFR also is a very important measure that you should consider doing, because the patients, those who have a high post-PCI FFR, you can see in the outcome difference, has a much better outcome than the patient who has continued to remain low FFR. So what could you do about that? If you do put a stent in somebody's LAD and you repeat the FFR and FFR is still 0.79, should you do something? So the clinical answer is yes. You might want to consider post-dilating the stent. You may have to add a second stent. Certainly, doing an OCT type examination on those patients will add a remarkably valuable information, because a lot of these patients might have edge dissection that can also be responsible for low FFR. You may have underexpansion of the stent, you may have malapposition of the stent that should be corrected. It has been shown that an additional intervention in 30% of patients will increase FFR value, as shown in this study in a post-PCI situation. FAME-3 trial is ongoing, which is going to specifically look at FFR-guided multivessel revascularization versus CABG. The results of this will be available in future and will shed further light to the concept of PCI optimization in patients with complex disease. So in conclusion, FFR is better at characterizing the nature and extent of the problem in patients with multivessel disease. It better defines when appropriate to revascularize and when not to revascularize, and is better at risk stratification, better identifying those that might benefit from multivessel PCI versus CABG. Thank you very much.